Hi, everyone. Welcome back. Today, we're joined again by Dr. Stenehjem to go over our community update on COVID-19, what's been happening in the past week since the last time we got together. Eddie, thanks again for joining us. We appreciate the time.
Yeah, absolutely.
So as always, I want to talk about case counts and just the numbers and data first. Again, this information was reported yesterday. We don't have today's numbers released yet, but our total case counts as of yesterday were 22,716 with 493 reported cases yesterday, just that day. We have a total of 173 deaths in Utah and 1,476 hospitalizations. Can we talk a little bit about how our ICUs and hospitals are doing and kind of break down those numbers a little bit more?
Yeah, sure. Yeah, you're right. So yesterday was another 500 case count day, 493, pretty close. We've had really over the past 10 days, almost every single day has been about 500 or more, topping out in the mid 600s. We've really seen that rise starting right around the end of May 27th, and has had a steady increase up. And we've now been relatively stable at about 500 to 600 cases per day for the past 7 to 10 days. In terms of our hospitalizations, I can speak to our Intermountain facilities. We're right around 170 to 180 patients admitted to all of our facilities for COVID-19. And that's up from about between 70 and 80 kind of mid-May period. And so we've seen a really significant increase in hospitalizations. And keep in mind that hospitalizations typically occur 5 to 7 days after somebody tests positive. And so we definitely see this delay. And so what we're now seeing is this increase due to the spike that occurred in mid-June and is carried forward. In terms of our ICU capacity, yesterday here at Intermountain Medical Center, we were at about 82, 83% full. Keep in mind, once you hit about 90% full, that's when patients are waiting in the emergency department. We're trying to board them somewhere else to turn over the rooms to get them in. And so being at 83 to 85%, that's really high. We've got multiple units here at Intermountain Medical Center, all converted over to COVID units. They're essentially all full. St. George down in, our hospital down in St. George is also really close to capacity as well. So I think right now we're maintaining, we're able to care for all of these patients in ways that our expectation is that they're cared by, intensive care unit doctors. We're giving them the advanced therapeutics that they can give. They're being seen by infectious disease and virtual rounding. And so we're okay, but the issue is we can't keep going. We can't tolerate another surge. The other kind of part in terms of our numbers is that we keep in mind that our test positivity rate has also gone up. So we're at about 10%. So if all the tests that we do, approximately 10% of them are positive. That number was 5 to 6% back in May. And so we've seen an uptick in that. And our number of tests that we've done has remained relatively stable. And so that's just really indicative of, testing staying stable, our percent positive going up. That's community transmission.
Yeah, I think it's also really important. I know we talk about this every week, but for people to really look at the positive rate as opposed to the case counts overall, because that's the numbers that are really going to matter. And emphasizing that our testing is not blown up. We're not all of a sudden testing way more people than we were in the past. So that's not why the case counts are going up. It's like you said, community spread. We're still seeing that spike from Memorial Day. So those are really important to look at. I want to talk about.
There's great data on the. Oh, go ahead.
Sorry, go ahead.
All right. I was just saying that, if people want to take a look, go to the Utah Department of Health website, look for the COVID section, and there's a great graphic of the number of people tested and those that are positive. And what you can see is that kind of the number of tests we've done has just kind of fluctuated over the past few months, right between 4,000 and 6,000 tests per day. But we're seeing more positives amongst them. So it's a really good data. The Department of Health website is excellent.
Yep, and it's updated around 1 p.m. every day too. So after people watch this, if they'd like to go get that most recent data, that's where they should go. I want to really quickly talk about too something that's been circulating on social media about the CDC, and that some states have been reporting antibody testing included in their positive case counts. And how Utah is not doing that. Do you want to speak a little bit to how we're reporting case counts and what we mentioned earlier about Dr. Dunn talking about that as well?
Yeah, I mean, this one's pretty easy. We do not count a positive antibody for SARS-CoV-2 as a positive case in our case counts. It's just that easy. The only tests that we use to really populate our case counts are the nasal swabs, those viral PCRs that we use. Those are the only things that populate our case counts. We don't count antibody tests for that. And Angela Dunn confirmed that, and it's also been on Twitter. So, you know, can't speak to other states, but here in Utah, we do not count a positive antibody as a positive test for our case counts.
You also just quickly mentioned the type of test it is. I have a question about that too. I know that other tests, specifically California, there is some sites that are doing throat swabs. What is the difference between the two tests, and is there a level of accuracy for one versus the other?
Yep. So this is, you know, these are tests that look for the virus. So these are not antibody tests, which are blood tests. So we're looking at viral tests that actually detect the RNA of the virus. And so there's tests that look into your throat. There's ones that are kind of in the front part of your nose, and then there's the ones that are in the back, your retropharyngeal. And so we use the deep nasopharyngeal swabs for our testing because those give the best results. There is data looking at what's called a mid-turbinate swab, which means you don't have to go as far in your nose, and then an oropharyngeal swab in terms of a throat swab. They all have a little bit different testing characteristics. The deep nasopharyngeal swabs are the best. They detect the virus most efficiently. But we're also looking at, and other states are too, are looking at oropharyngeal and mid-turbinate swabs. And those are just different testing methods. The reason that it would be nice to use those is that when you do a deep swab, you're at risk for coughing. And if you cough, you can aerosolize the virus. And that means that the people that are obtaining the test need to be in the appropriate PPE in case that person were to cough. If you could use an oropharyngeal or mid-turbinate swab, you know, a patient could collect their own swab, which would be very beneficial from a collection strategy. You could even do mail-in swabs. There's a whole bunch of things you could do if those tests would actually give the best testing characteristics. We don't want to, you know, decrease our ability to detect the virus just so we could use a different test. We want to make sure that we still can detect the virus most efficiently. And right now, that's the current swab we're using, the nasopharyngeal. But we're looking at alternative methods, especially as this epidemic moves on into the summer and fall and winter.
Another thing we mentioned too was in terms of antibody testing, we were talking about something called the HERO study, which was done here in Utah. Will you give everyone an update a little bit about what we've learned so far with antibody testing, if it's worth the testing that we're actually doing, and just an overall view of everything?
Right. Yeah, there was a nice report. The University of Utah, in conjunction with the Utah Department of Health, did a study. They called it the HERO study, where they went and they did random sampling in 4 counties looking for antibody levels. And so they did Park City, a number of places here in Salt Lake County. And what they found was that in average, we have about a 1% positivity rate for antibodies for this virus. And so that was after sampling thousands of people. And this was back in May. So keep in mind, this data reflects May data. So about 1% of the population has antibodies for SARS-CoV-2. That's what we can say. It was a little higher in Park City with 3%, a little lower in some other areas, but on average, it's about 1%. And so it just gives you an idea back in May, kind of what our prevalence rate of this infection was. It was 1%. It was pretty low. And that really, I think, is indicative of what we did as a community in terms of flattening the curve. And so we did really well initially up front, April and May, in keeping those case counts low. And because of that, not many people got infected, and we've got about 1%. And so they also did some estimates on the fact that we are missing some people. You know, there's plenty of people that get sick, either they're asymptomatic or they get sick and don't get tested, that this, you know, seroprevalence study detected. But we're doing a pretty good job of testing. So 1%, and if you keep in mind, you know, herd immunity, if that exists for this infection, that doesn't happen until we get to 65 or 70%, you know, positive from an antibody level. So we're a long ways away from that. And granted, this spike is going to certainly increase our seroprevalence, but we're a long ways away. And it should also be noted that we still don't know what a positive antibody means. All we can say is that it means that you've been infected previously. That's about it. But we are starting to learn the fact that antibodies do wane over a number of months, and that if you are asymptomatically infected, your antibody level is lower than those that are symptomatically infected. And so we're going to know much more in the next few months as the opportunity for reinfection occurs in those that were previously infected. And we'll just have to wait and see if that actually happens.
That's interesting, the 1% to the needing the 65 to 70% for herd immunity. It kind of really shows you how far away we are from that. I see a lot of people thinking about herd immunity. Everyone just needs to get it so that we can get over this and get back to our life. But what you just said shows that we're very, very far away from actually reaching that herd immunity. So I think that's really important to know.
Right. And if we go from 1% to 65% in 1 year, that clearly will outstrip our capacity of all of our hospitals across the state of Utah. And so that is just not an option for us in terms of developing herd immunity.
I want to switch gears a little bit to masks. We're just going to touch base on a couple of things that have come up in the last week that we've seen. A couple of things that I've seen floating around on social media. One has to do with an OSHA comment that's been copy and pasted through a bunch of different platforms. The three main points of this post said that N95 masks exhale breath, so they're not actually filtering the virus, that surgical masks are only meant to be used in a sterile environment, and that cloth masks don't filter anything at all. I want to debunk those three things really quickly and just talk about maybe if you can talk about the purpose of an N95, the purpose of a surgical mask, and then why cloth masks have been proven to actually work.
Yeah, so N95 masks are masks that we use in the hospital for airborne viruses and infections. So think tuberculosis, think measles. These are the most effective masks. They're very thick. They form a very tight seal to your face. And in order to use one of these masks in a healthcare environment, you have to get what's called fit tested, meaning you have to wear this mask, put a hood on where they put in a very distinct gas that you can smell. And you have to ensure that when that mask is on, that you can't smell that gas that they're putting in this hood. So it's a pretty extensive procedure in terms of getting fit for one of these. But it offers incredible protection of minimizing what you inhale and obviously filtering that. So those are medical grade N95s. And we wear those when we're doing aerosolizing procedures in patients that have COVID-19, people that are on ventilators. Those are the most protection. What you do see though, is that there are industrial grade N95s that have an exhalation port. And these are masks that you can buy at Home Depot. You can buy them at Lowe's, and they're meant for people that are working in the field with noxious gases or sawdust and those types of things that need to protect them from inhaling that particular noxious fume. But what that exhalation port does is it allows them to exhale easier. Okay, and so those industrial grade masks aren't meant to to be used in the medical field. They're used in the industrial field, and it makes them so they can exhale easier, which medical grade masks don't have. And so we definitely don't want to be using the N95s with the exhalation port, because if you have coronavirus, you're just going to be exhaling that coronavirus right out into the atmosphere. It'll protect you from getting exposed to somebody with coronavirus and their virus. But if you have the virus, you're just going to be expelling it out into the community. So we definitely don't want people using the N95s with the exhalation port. That's point number one. In terms of surgical masks are very good masks. They're made with multiple layers. These are the type of masks that are used around the world in terms of prevention respiratory infections where people don't have N95s. They're proven effective in terms of influenza and other respiratory viruses and preventing the wearer from getting the infection. These are masks that we wear when we take care of COVID-19 patients here on the floor. That's the level of protection that they offer, is that our healthcare workers aren't getting sick wearing these masks, taking care of COVID-19 patients. And if you have the virus and you wear a mask and you breathe through the surgical mask, you aren't expelling virus into the community. Okay, it's not as effective as an N95, but it's really pretty good. And there's data that's been published in Nature magazine and Health Affairs that have shown the effectiveness of these masks, both in laboratory conditions and also in the real world. Now, the cloth masks, ideally a number of different layers of cloth. Really what they're intended for is that if that person has coronavirus, whether they're symptomatic or asymptomatic, and they're wearing a cloth mask, that those big respiratory droplets, the droplets that carry coronavirus, not the virus itself, which is very, very small, but the respiratory droplets that are carrying it, if you breathe through a cloth mask, those respiratory droplets get stopped and you're not transmitting coronavirus into the community. Those are things that you can wash, and we expect you to wash them often. But their whole point is to minimize the exhalation of coronavirus into the community. They likely have some protection if you encounter somebody with coronavirus. We just don't know to what extent. Hopefully that answers the questions.
Yeah, I think that's super helpful to define those three different things. I also want to ask you a really quick question. There's been an image circulating of a surgical mask box that says that it doesn't prevent or protect against COVID-19. And people have been posting this image. I actually haven't seen if the surgical mask box really does have that, or if it's just something that's been kind of floating around. Would there be a reason why a company would put a label on there that says does not prevent or protect against COVID-19?
No, I have no idea. I mean, just to be very clear, we use surgical masks in the hospital caring for patients with coronavirus. Okay, and when you look at the number of employees that are getting infected from coronavirus, it's very, very, very small. Okay, so these are the masks that we use, that we entrust our caregivers with to take care of these patients with active coronavirus disease. These masks work. And that's all we can say, is that a surgical mask does prevent people from getting infected from coronavirus.
If I had a box, I would actually go look. Maybe we'll go investigate that later. And that brings up one more thing, and then I have a couple more questions for you. A lot of people have been talking about the lowering of oxygen when we're wearing a mask, and I think it'd be really interesting. You talked about the study you guys did in Park City, but it'd be really interesting to see what happens if you took someone who has asthma or claustrophobic and kind of see if their oxygen levels went down or not. Have you guys done anything like that so far, or are we still kind of waiting to see what happens with that?
Yeah, no, I mean, it's interesting. There's a number of Twitter pictures and photos of physicians and healthcare workers wearing N95 masks, taking a pulse oximetry and showing that clearly it's not a reduced oxygen requirement. One of our very own, Mark Lewis, who's an oncologist who has got a huge Twitter follower, actually put on an entire box of masks and took his O2 reading, and it was very stone cold normal. This isn't a study we need to do, Amanda. This is based in decades of science. Surgical masks do not lower your oxygen levels and do not increase your CO2 levels, period. I mean, it's not a question that warrants, scientific study. It really isn't. This is something that we know and is rooted in fact. So, I don't know more to say. They don't lower the oxygen requirements or oxygen levels in people that wear them.
And I think it's important with the Mark Lewis thing to point out for everyone that he didn't waste all the masks. He's using them himself again. Right. So he did not waste an entire box of masks. If you go look at the tweet he put out, he talks about that he's only touched like the very top one and will be reusing them just for himself. So important clarification there. Okay, a couple more questions for you. So I want to talk about vaccines and any therapeutic drugs that have been in the works in the last couple of weeks, and if we've had any progress on finding drugs that are helping people get over the symptoms of COVID-19.
Yeah, let's first start with vaccines. There's two really leading vaccine candidates. One's from Oxford University, is paired with AstraZeneca, and the other is the Moderna vaccine, which is in conjunction with the NIH. Both of those have now started phase 2/3 trials. The Oxford vaccine is launching a big phase 3 trial in Brazil that is having very high case counts. In addition to the UK, The Moderna vaccine, which is a US-based vaccine, will be launching their phase 2/3 study very soon in a number of NIH trial sites across the US. Those are the two that are leading the pack and farthest along. They've had relatively good initial results in phase 1 studies, and so we're cautiously optimistic, but we won't know any definitively for a number of months. The Pfizer vaccine just released data from their phase 1 trial, and that looked promising as well, and we'll be moving on to phase 2 studies here shortly. So we are making progress from a vaccine standpoint. You're going to see more data coming through in the coming months, but in terms of a production-ready vaccine, we're still thinking earliest would be this winter. And again, that wouldn't be able to produce enough vaccine for the entire population of our globe. And so even if they do produce a vaccine, we'll have to go through the process of who's going to get it first, what makes more sense, and go from there. In terms of therapeutics, right now we have one antiviral agent called remdesivir that has been shown to be effective in a few studies. And that is being used across the state of Utah. We have state-based allocation of remdesivir because the supply is so low. And so we still have remdesivir, and we're using it on specific patients that meet the threshold of requirement in terms of oxygen status. And then the drug that just recently got some news was dexamethasone. So this is a steroid that we've used for decades. This was a study in the UK called the Recovery Study, and they have an arm of the study that studied steroids that showed that in the most severely ill patients, those that are on the ventilator or those on really high flow oxygen, dexamethasone actually reduced the mortality of those people. And so we've reviewed that study, and we've now incorporated dexamethasone into our treatment guidelines, and we're now using dexamethasone throughout all our facilities. And this is all organized through a very complex COVID-19 rounded structure that we have, where ID physicians and researchers are going through every patient across our system and ensuring they're on the correct therapeutics. So those are the big updates. We've got a number of kind of medications kind of in the pipeline that are really interesting. One of them is called a monoclonal antibody against the virus. And so what this is a manufactured antibody that targets specifically the spike protein on SARS-CoV-2, and that's entering trials now. So that's really interesting in terms of a potential therapeutic. So lots in the pipeline. We're continuing to bring on studies within our Intermountain Healthcare hospitals to really understand what works for these patients and what's going to offer them the biggest chance of survival. So that's really the update in terms of vaccines and therapeutics.
It's good to hear that we're hopefully moving in a good direction. We've gotten a few questions on Facebook that I'm just going to ask you really quick. Someone wants to know if you think schools can really reopen in August, which is only a month from now, which is slightly crazy that we're in July, but any thoughts on how schools would reopen?
Yeah. So I'll give you my thought as an infectious disease doc epidemiologist, not as an elected public official. I don't see how we can safely open school if our case counts continues to go up. Okay, so we have over 3 times the amount of cases now on a daily basis than we did back when we closed schools back in April, back in March. And so with these case counts going up, if they continue to be this high or they continue to go up, I just don't see how we can safely open schools. If we really rally as a community, if we all wear our masks, if we do physical distancing, we limit our social gatherings, we stay outside, and we see these case counts drop off and back to levels like we were back in April and May, then I do think we're in a position where we'd like to open schools. I mean, opening schools would do so much for the economy, and the fact that if you open schools, parents can go back to work, but we have to be able to do this in a safe manner. And I just don't see it if our case counts continue to rise like they are. And so the next few weeks are going to be really, really telling in terms of plans to open schools. And if they do open schools, we really need to have a really critical focus on how do we do it? How do we make sure that our students are 6 feet away? How do you get them to wear masks? Hand washing, don't touch your face, all those things have to be integrated into schools. And so I guess we'll see what happens in the next few weeks, and then whether or not that is going to impact whether or not we open schools.
Another question we got, and forgive me if this doesn't make 100% sense, because I'm going to read it off to you. Someone said, my roommate tested positive for COVID and I had all the symptoms, but tested negative 3 separate times. I also tested negative for antibodies with a blood draw. She tested negative for antibodies with a finger prick. How much can we trust both the nasal swab and the antibody test? So it sounds like one person tested positive for COVID, but negative for antibodies, and then the roommate tested negative for both.
Yeah, roommate's negative. Roommates had 3 negative nasal PCRs and a negative antibody. Each test individually is pretty good, has 95% positive predictive value. So at least for the nasal swabs. So 3 negative nasals and a negative serology, as long as that was after 14 days after exposure, that roommate's negative. There's no more testing that needs to be done for that person. In terms of the individual that did have COVID-19, which I'm assuming was positive from a nasal swab, we know that the finger prick tests aren't that great. And so they're not as reliable as a full blood draw. And there are people that don't generate an antibody response to the infection. And so we know that as well. So now there's at least 2 reasons why that antibody test could be negative. In addition, it has to be done at least 14 to 21 days after the onset of symptoms. So if they had done it earlier, it may not have been positive for that reason. So, I can say roommate, negative, all good. The person that was infected, if you really wanted to get an antibody level, which I don't see any need to, you already know you're positive, then I would make sure you get a blood draw. And if you're negative, you're just one of those people that didn't generate an antibody to SARS-CoV-2.
That's interesting to note. Okay, last question from Facebook, and then we'll wrap up. Someone wants to know how safe it is to go through a drive-through testing site, and if you can contract COVID-19 by going to get tested. A lot of hospitals, including ours, are requiring pre-surgery people to go get tested. So can you talk a little bit about what we're doing to make sure people are safe?
Yeah, exceedingly low in terms of a risk of getting infection going through one of the drive-through sites. All our people are in personal protective equipment. They're changing gloves between individual testing. And so the chance, and then people are staying in the car, they're not being exposed to people. So the chance of getting SARS-CoV-2 by going through a testing site is exceedingly low. And we have not had any reports that that's actually happened. And we take lots of precautions to ensure the safety of the participants that come through.
Yeah, and I think that if you do go, you'll get that sense that you are very safe. All of our caregivers are given a lot of training on how to take care of the samples, what happens with them. So yes, rest assured you are safe to go get tested, and especially if your doctor is wanting you to go get tested, it's very important to go do that. Tony Wallen too on Tuesday mentioned if you are going to get surgery, we recommend you get tested within 72 hours of your surgery, and then you self-isolate. That way you're not going back out into the community and risking yourself actually getting COVID before you go to surgery. So to the person that asked that, if you're going to get tested, please make sure you self-isolate after you go get tested. Last question for you. This weekend is the 4th of July. It's typically a weekend we all gather with friends and family and have a really fun time. Any tips, tricks, thoughts on how we keep ourselves safe? Because I don't want people to forget that we're still in a pandemic and it hasn't gone away.
Yeah, quite the contrary, right? So I think a couple points on not only this holiday, but Pioneer Day coming. I think the biggest thing that we need people to know is that your healthcare systems can't tolerate another surge equivalent to what happened after Memorial Day. We saw this huge uptick in cases after Memorial Day. We can't keep going in this pattern and be able to offer 100% excellent healthcare. Okay, so first and foremost, we have to flatten this curve now in order to allow us to continue to provide exceptional healthcare. So that's the first thing. And so people really need to understand the why behind this. The why is that our healthcare providers are taxed, our ICUs are full, our floors are getting full. We can't keep going in this trajectory. and provide the care that we want to be able to provide. Okay, so that's number one. So what do? It's July 4th. You're right. This is a big holiday for us. It's a summer holiday. I guess some things to keep in mind. First thing is physical distancing holds true here. And so if you're going to be gathering, really try to focus your gatherings on groups that are smaller than you would otherwise. And so, less than 10, less than 15 people, really minimize the contact you have with other people. The more people you bring in your mix and bring in your circle, the more likely you are to be exposed to somebody with COVID-19. So try to minimize the number of people you're encountering. And two is all of those activities need to be outside. There should be no indoor parties, just period. And fortunately, we got great weather this weekend. And so all parties, all gatherings, people, 10 to 15 people, get them outside and try to space out a bit. Don't be sharing drinks, don't have communal cups. Really try to focus on, good hygiene at those gatherings, wash hands, those types of things. You can still enjoy fireworks, but do that isolated. Make sure that your groups are separated by 6 feet. You're obviously outside for those. And so those are the biggies. Now, if you go out and you are encountering commerce, you're going out into our facilities or Home Depot, whatever it is, put on a mask. This isn't up for debate. In Salt Lake County, we've got a mandatory masking policy. It doesn't matter where you are, put on a mask. And so whether it be a cloth mask or surgical mask, just wear a mask to really protect the community from this virus, because we know that transmission occurs in people that are asymptomatic or minimally symptomatic. And so those would be kind of my parting words. It's something that we have to do for this community. If we want to be able to maintain the healthcare that we've come to expect, the community needs to help us. And that part is really physical distancing, get outside, and wear masks.
Great advice. I think that's good to end on. I know there's a few remaining questions on Facebook. If we didn't get them to them live, I'll answer them for you guys later. So the people who asked some questions, we'll get to those later today. But Eddie, thank you so much for joining us. We really appreciate the time. And just a couple of phone numbers for you guys really quickly. We still recommend you call our COVID-19 hotline before you show up to a testing site. That way you can get screened and qualified before you show up. That phone number is 844-442-5224. There are some longer wait times currently on that phone line, so please just be patient with us as we get through people. We're trying to make sure you're all safe and that you can get adequately tested, so just keep that in mind. We also still have our emotional health relief hotline available 7 days a week from 10 a.m. to 10 p.m. That phone number is 833-442-2211. And please remember this weekend to wear a mask and be safe. Thanks, Eddie. We'll talk to you next time.
Thank you.